Imagine walking into a high-end medical spa. You've got the cucumber water and a crystal pitcher. There's like ambient music playing softly in the background.
Oh, absolutely. The whole luxury experience.
Right, and right there on the glass coffee table, there's a stack of glossy brochures offering to rejuvenate you.
Mhm.
Now, usually you would assume they're talking about a chemical peel for your face or, I don't know, a new serum for fine lines.
Right, something topical.
Yeah, but today, in this deep dive, the brochure is actually talking about your internal organs.
It's quite a jarring pivot, isn't it? I mean, we are very accustomed to the language of aesthetics when it comes to what is visible on the surface, but applying that exact same language internally, well, it completely changes the context of what we're actually discussing.
Which is what
It's medical intervention, pure and simple.
And that is exactly the mission of our analysis today. You, our resident learner, are coming with us as we cut through all this marketing hype. We are looking at a huge stack of medical sources, clinical guidelines, and even an actual manufacturer's consent form.
Which is eye-opening, to say the least.
Oh, totally. Because we're looking at a massive trend in women's health right now, which is non-surgical vaginal tightening. Okay, let's unpack this. Specifically, we're going to do a deep clinical comparison of the two main technologies dominating this space, which are laser versus radiofrequency or RF energy.
It's a topic that really demands absolute clarity because the term vaginal rejuvenation, which features, so prominently in those spa brochures, is described in our sources from the European Medical Journal as an industry-driven misnomer.
An industry-driven misnomer. I like how they put that.
Right. It frames a really complex physiological change as a cosmetic flaw, like it just needs a quick polish at the salon.
Yeah, it makes it sound like getting your nails done. But to understand why these laser and radio frequency machines even exist in the first place, we have to look at the underlying biology.
Exactly. We have to start with the tissue itself.
Yeah, like why are women seeking this out? Because, they are dealing with very real, very frustrating quality of life issues here.
They absolutely are. The medical literature points to two main underlying conditions driving this whole demand. The first one is GSM, which stands for the genitourinary syndrome of menopause.
Okay.
So this is a chronic, progressive condition, and it's triggered by a drop in circulating estrogen. When your estrogen levels fall, the vaginal mucosa, so the cellular lining, drastically thins out.
Right, because estrogen is what keeps that tissue plump and healthy.
Exactly. And the sources note a staggering structural change here. Less than 10% of the superficial epithelial cells actually remain.
Wait, less than 10%? So you're losing over 90% of those surface cells.
Yes, it is a massive biological shift.
Wow. Let's look at the cascade effect of losing 90% of those cells. Because the sources say that with fewer of those epithelial cells, the tissue's glycogen levels just plummet.
Right.
And glycogen essentially acts as like the food source for the healthy bacteria in the vaginal microbiome, specifically the lactobacilli.
Exactly. You are literally starving the lactobacilli. And when you do that, their populations decrease. Now, those bacteria are responsible for maintaining the acidic environment of the vagina. So without them, the natural pH rises above a 5.
Which changes everything about that ecosystem.
It really does. This ecological shift leads to profound dryness, loss of elasticity, an increased risk of infections, and significantly, dyspareunia.
Which is pain during sexual intercourse, right?
Correct. The tissue basically becomes incredibly fragile. It loses its robust protective qualities.
Okay, so that is GSM. But then there is the second major condition our sources highlight, which is SUI, or stress urinary incontinence.
Right, which is incredibly common.
Super common. This is the involuntary leakage of urine when you cough or laugh, sneeze, jump on a trampoline, exercise. It's really common after the physical trauma of childbirth or even just the natural aging process, which can stretch and weaken the pelvic floor.
Yeah, you essentially lose the muscular support that holds the urethra and the bladder neck in place.
To kind of visualize this, I always think of the pelvic floor and the vaginal tissue like a trampoline.
Oh, it's a good analogy.
Right. So the muscles are the springs and the tissue itself is the fabric. So over time or after having a baby, the springs get stretched out and loose and the fabric wears super thin.
Yes, and when intra-abdominal pressure increases, like when you sneeze those weakened springs, those muscles, they cannot counteract the pressure, so you get leakage.
Okay, but here's my question. I am looking at the guidelines from the British Menopause Society regarding both GSM and SUI. They explicitly state that the first-line gold standard treatments are vaginal estrogen to restore the fabric and pelvic floor physiotherapy to tighten up the springs, plus bladder training.
That is the gold standard, yes.
So if the medical community knows exactly how to treat the mucosal thinning and the muscle weakness safely, why on earth is there such a massive rush toward these really expensive energy devices?
It's a great question. The intersection of biology and our modern lifestyle creates this unique pressure point. Those traditional conservative treatments you mentioned, they absolutely work. But they demand time and a lot of consistent effort.
Like going to physical therapy every week.
Exactly. Pelvic floor physio requires months of dedicated daily exercises to rebuild that muscular support. And vaginal estrogen takes weeks to show symptom relief. Plus, it requires ongoing, sometimes indefinite application.
And it can be messy, right? People just stop doing it.
Exactly. The compliance drops off significantly over time. Women get busy, they forget, it's inconvenient.
But there's also a group of women who just literally cannot use estrogen, right?
But that is a crucial point.
Right.
There is a substantial population of women who cannot use it.
Yeah.
For breast cancer survivors, particularly those who are on aromatase inhibitors, which are drugs that intentionally suppress estrogen to prevent the cancer from coming back, hormonal treatments are often completely contraindicated.
Or just highly undesirable for the patient. They don't want to risk it.
Right, so you have this massive population of women dealing with really debilitating symptoms, a desire for a fast solution that bypasses daily regimens, and a specific subset of patients who desperately need non-hormonal options.
That creates a huge market demand.
A powerful market demand for a quick, non-surgical intervention.
Which brings us to the core of our deep dive, the actual machines that are promising to repair this tissue using light and heat. Here's where it gets really interesting.
It does.
The sources give us a direct mechanical comparison of the two technologies that are trying to stimulate the body's natural healing pathways. Laser versus radiofrequency. Let's start with lasers and how they actually approach the tissue.
Okay, so both of these technologies operate on the exact same fundamental principle, which is controlled damage.
Wait, they're intentionally damaging the tissue?
Yes, they intentionally injure the tissue to provoke a healing response. Specifically, they want to trigger neocollagenesis, which is the creation of fresh new collagen fibers, and neovascularization.
Which is new blood vessels, right?
Exactly. To restore blood flow and bring nutrients back to the area. Lasers achieve this controlled damage using focused light energy. But the medical sources highlight two vastly different types of lasers used in these clinics. You've got CO2 lasers, and you've got erbium.YAG lasers.
Okay, so let's break this down. The CO2 lasers, those are devices like the Mona Lisa Touch or the nYou, right?
That's right.
My understanding from reading the literature is that CO2 lasers penetrate deeply into the tissue. They literally vaporize the water in the cells that they hit.
Yes, vaporization is exactly what's happening.
So they're basically creating microscopic columns of thermal injury, essentially tiny controlled burns deep into the mucosa.
Yeah, and this deep thermal effect is highly efficient at stimulating the fibroblasts, which are the cells responsible for making that new collagen. But because it is an ablative process, meaning it actually destroys a fraction of the tissue, it causes significant heat diffusion into the surrounding areas.
So the body basically freaks out and mounts a huge inflammatory response.
Exactly. It has to mount a robust inflammatory response to clear out all those vaporized dead cells and rebuild those micro-injuries from scratch.
It sounds effective, but pretty aggressive.
It is aggressive, which is why some clinics prefer the other option.
Right, the erbium.YAG lasers, like the smooth device. The sources get quite specific here, noting that the erbium laser operates at a wavelength of precisely 2940 nanometers.
And that specific wavelength fundamentally changes how the energy interacts with the tissue.
How so?
Well, at 2940 nanometers, the erbium laser has 10 to 15 times the affinity for water absorption compared to a CO2 laser.
10 to 15 times. That's a huge difference. I was reading about this water affinity thing in the sources, and the best way I could visualize it is to think about how a microwave works.
Oh, that's interesting. Go on.
So a microwave doesn't actually heat the ceramic plate you put your food on, right? It specifically targets the water molecules inside the food, exciting them to generate heat.
Right.
So the erbium laser is tuned so specifically to water that it targets the moisture right at the very surface of the vaginal tissue. It gets absorbed so rapidly by that surface water that the energy literally cannot penetrate deeply like the CO2 laser does.
That is exactly what happens. The result is a much more superficial and precise treatment. It just gently heats the surface tissue, just enough to break the cross-links in the existing collagen fibers.
So it's shrinking them.
Yes, causing them to shrink and tighten up without actually vaporizing or destroying that delicate surface layer of the mucosa. It achieves a thermal effect without the severe ablation.
Okay, so we have CO2 going deep and vaporizing things to trigger a heavy inflammatory healing response. And then we have erbium staying shallow, using its water affinity to basically heat and shrink the surface collagen.
Right, those are your laser options.
But then we have this entirely different modality, which is radiofrequency or RF devices. These are machines like Fermiva or Abivev. The sources make a really sharp distinction here because RF does not use light energy at all.
No, it doesn't. Radiofrequency uses alternating electrical current to generate heat through tissue resistance. So it relies on electromagnetic waves.
Okay, so instead of a laser beam ablating the surface or heating that superficial water, RF sends these electromagnetic waves to heat the deeper submucosal tissues, completely bypassing the surface mucosa entirely.
Exactly. It leaves the top layer completely untouched while creating bulk heating underneath it.
And bypassing the surface changes the clinical experience for the patient entirely, doesn't it?
It really does. The sources point out that RF is generally considered gentler. Patients often describe the sensation as just feeling like a warm massage.
A warm massage versus a controlled burn.
Exactly. Clinically, this makes RF less painful and generally safer for women who have highly sensitive or severely atrophic paper-thin skin due to advanced GSM.
Right, because if the tissue is incredibly fragile, sending a CO2 laser in there to vaporize it might just be way too aggressive, so RF becomes the more comfortable route.
However, the sources also note a really fascinating clinical nuance here. Lasers, specifically because of that ablative microinjury, are often the preferred choice for postmenopausal dryness.
Wait, really? Why?
Because the aggressive destruction of the tissue seems to prompt a much more vigorous rebuilding of the mucosa and restoration of natural lubrication compared to just heating it.
Oh, wow. So you have to really weigh the comfort versus the intense healing response.
Exactly. But regardless of the mechanism, whether a patient opts for the deep ablation of CO2, the superficial water targeting of erbium, or the deep tissue heating of RF2, the clinical protocols for all of them are surprisingly similar.
Yeah, they're all outpatient procedures, right?
Yeah, they require very little downtime, maybe just a few days of pelvic rest. And crucially, they all require multiple repeat sessions to get results.
Which brings up a huge point. Because these treatments are not cheap, we are talking thousands of dollars, so we have to look at the long-term efficacy.
We really do.
We know the mechanisms now. Controlled injuries or deep bulk heating leading to fresh collagen. But what does the actual clinical data say about the longevity of these results? Like, are we actually curing GSM and SUI, or is this just a temporary inflammatory plumping effect?
Well, when we look at the broader picture of medical evidence, and this includes the really comprehensive review from the Royal College of Obstetricians and Gynecologists, a glaring methodological issue emerges right away.
Yeah, the data is weak.
Extremely weak. The vast majority of studies supporting these devices are small, short-term, pilot observational studies.
Meaning they lack a placebo control group, which is a massive red flag when you are studying conditions like sexual dysfunction or incontinence, where we know the placebo effect can be remarkably strong.
Exactly. And furthermore, they are not tracking these patients for 3, 5, or 10 years. They're tracking them for a few months.
Right. And in the short term, the data does show promising symptom relief, doesn't it?
It does. For the first several months post-treatment, patients do report subjective improvements in dryness, pain, and laxity. And those improvements are statistically comparable to the relief achieved from topical estrogen therapy.
Which sounds great, but the clinical durability just falls off a cliff.
It completely plummets.
The evidence indicates that the physiological effects of these energy treatments fade drastically after about 12 to 18 months. After a year and a half, the patient's symptom scores generally return to their exact pre-treatment baseline.
Which means, to maintain the effect, a patient is locked into a cycle of annual or semi-annual top-up treatments basically indefinitely.
Forever.
Yeah. And this perpetual treatment model raises significant questions about the long-term changes occurring in the tissue. If we are repeatedly inducing thermal injury and scar tissue formation year after year, we simply do not have the longitudinal data to say what that vaginal wall will look like or function like a decade from now.
That is terrifying. And honestly, the financial burden of endless treatments is one thing, but the physical risks are what truly stand out in the sources. I want to look specifically at the consent form for the V-Wave RF device,
Ah, yes.
because the language used in the actual medical legal documentation is a stark contrast to the language used in those glossy spa brochures we talked about.
It is a profoundly sobering document. The marketing materials heavily emphasize restoring youth, effortless tartning, a return to normal function.
Yet the actual consent form you have to sign explicitly states, and this is in bold print, there is no guarantee of results.
Right.
It then proceeds to list a series of potential adverse effects that are severe. It lists transient swelling and pelvic pain, which, okay, one might expect from a heat-based treatment. But then it lists altered sensation,
Yes.
defining it as permanent numbness or tingling in the vaginal region. It lists excessive tightness that can actually interfere with sexual activity, which is deeply ironic given that many women seek this out to improve sexual function.
It's totally counterproductive.
And most alarmingly, it lists potential damage to the urinary bladder and the urethra.
Bladder and urethral damage, resulting from a treatment ostensibly marketed by many clinics to help cure urinary incontinence.
It makes no sense.
It is a profound contradiction. What's fascinating here is how the medical aesthetic industry justifies spa-like advertising when the legal documentation warns about permanent numbness and organ damage.
How do they justify it?
We're observing a systematic shifting of the burden of risk directly onto the patient.
Oh, wow.
The consent form accomplishes this by clearly stating, usually in the fine print, that the treatment is being performed off-label.
Off a label. Okay, so that means the regulatory bodies like the FDA in the United States or the MHRA in the UK have not explicitly approved the device as safe or effective for this specific medical use.
That is exactly what it means.
Which brings us to this massive regulatory loophole surrounding these energy devices. Because if the results fade after 12 months and the risks include bladder damage, how are these machines so widely and illegally advertised for vaginal rejuvenation?
We have to look at the gap between technological innovation and regulatory oversight. The FDA and the MHRA regulate medical devices, and they have emphatically not approved these laser or RF devices for the treatment of GSM, SUI, or any form of vaginal rejuvenation.
But wait, I have seen numerous clinic websites that display a shiny FDA-approved badge right next to their laser packages.
No, it is a regulatory sleight of hand.
How is that legal?
They are utilizing the FDA's 510(k) clearance pathway. The devices themselves do have FDA clearance, but they are cleared for general gynecology and general surgery. Specifically, they are cleared for the incision, excision, ablation, vaporization, and coagulation of body soft tissues.
So basically, the regulatory bodies cleared them to be used as highly precise, very expensive scalpels.
Exactly. They are authorized to cut or destroy tissue, such as removing a wart or a precancerous lesion.
Oh, I see.
So once a device is cleared for general soft tissue destruction, clinics purchase them, and then they use them off-label for cosmetic tightening or treating the symptoms of menopause.
And doctors are legally permitted to use devices off-label based on their own clinical judgment, right?
They are. However, the device manufacturers and the medical spas often blur the lines in their consumer advertising. They heavily imply that the FDA has vetted and signed off on the rejuvenation aspect, which they absolutely have not.
And the situation became so egregious that back in 2018, the FDA actually issued a public safety communication. They explicitly warned patients and healthcare providers against using these energy-based devices for vaginal cosmetic procedures, citing serious adverse events including vaginal burns, scarring, and persistent pain.
That's right. And if we connect this to the bigger picture, the European Medical Journal article introduces a highly relevant and chilling historical comparison to this exact regulatory environment.
Right, they invoke the legacy of the vaginal mesh fiasco.
Yes, which is a very heavy comparison to make in gynecology.
It is. The transvaginal mesh crisis is one of the darkest chapters in modern women's health. For you listening who might not be familiar with the specifics of it, basically, the medical device industry introduced surgical polypropylene mesh to treat pelvic organ prolapse and stress urinary incontinence.
Right. And it followed a very similar trajectory to what we are seeing right now with energy devices. The transvaginal mesh was heavily marketed as a revolutionary, minimally invasive fix, and it was rapidly adopted by surgeons globally.
But the problem was, it was pushed into the market with minimal, robust clinical evidence and a severe lack of long-term patient registries to track the outcomes over the subsequent decades.
Exactly. Without those long-term registries, the medical community just didn't realize the catastrophic effects until it was too late. The mesh literally began eroding through the vaginal walls. It caused severe chronic pain, repeated surgeries, and irreversible nerve damage.
And it resulted in massive, complex global litigation and the eventual withdrawal of many of these mesh products from the market entirely.
It was a disaster. So the EMJ article uses this history as a massive red flag. The core question being asked by cautious medical professionals right now is, are we repeating the exact same systemic mistake with energy devices?
Yeah, are we allowing industry-led introductions and heavy consumer marketing to outpace systematic, evidence-based medicine? Because we are permanently altering the structural integrity of the vaginal wall without 10-year outcome data.
Exactly. And right now, the surgical and gynecological world appears completely split on this issue. On one side, there are the early adopters who have purchased these six-figure machines for their clinics.
And some are undoubtedly chasing the lucrative private income stream that aesthetic gynecology provides. Though, to be fair, others genuinely believe in the innovation and report positive feedback from their immediate patients.
True. But on the other side, you have cautious evidence-based practitioners demanding to see the randomized, double-blind, long-term trials before firing lasers at delicate internal tissue.
So, what does this all mean for the authorities? Because when facing that kind of clinical uncertainty, especially with patient safety on the line, the major medical authorities have to intervene, don't they?
They do. And the National Institute for Health and Care Excellence, or NICE, along with the Royal College of Obstetricians and Gynecologists, have issued very strict, definitive guidance on the matter.
Right. They state that transvaginal lasers and RF devices should currently only be used in a highly controlled research setting.
Meaning as part of a registered clinical trial where adverse events are rigorously tracked.
Not in a private aesthetic clinic on a Tuesday afternoon.
Exactly. Furthermore, they stress that any patient considering these interventions must be fully and thoroughly counseled on the conservative options first. The topical estrogens, the pelvic floor physiotherapy, the specialized lubricants.
Because the medical community possesses decades of longitudinal data on the safety profiles of topical estrogen and physio, we understand exactly how the body processes them over a lifetime. We just do not have that data for repeatedly microwaving or vaporizing the vaginal mucosa.
Which is why the distinction between a proven clinical therapy and an experimental aesthetic intervention is so vital here.
So let's distill all of this for you listening right now. We have taken a really hard look at the physical mechanics of these heavily marketed treatments. We understand how CO2 lasers vaporize deep thermal columns to prompt an inflammatory healing response.
Right, and how erbium lasers specifically target water molecules for a more superficial collagen shrink.
Yep, and how radiofrequency utilizes electromagnetic waves to gently heat the deeper tissue while completely sparing the surface.
We have also seen that while the short-term symptom relief over the first few months is promising, the actual clinical science is lagging far behind the aggressive marketing.
The effects reliably fade after a year and a half. The risks of permanent nerve or bladder damage are real, and they are documented right there in the consent forms. And the major regulatory bodies are urging extreme caution due to the total lack of long-term safety data. If you are out there dealing with the incredibly frustrating reality of stress urinary incontinence or the dryness, thinning, and pain associated with GSM, we want you to know you are absolutely not alone.
Not at all.
These are valid, incredibly common medical issues that deserve attention. But your first step should be a thorough evaluation with a medical doctor to discuss pelvic floor physiotherapy, bladder training, and localized estrogen.
Right.
It should not be a consultation at an aesthetic clinic offering a non-refundable package of off-label laser treatments. Foundational medical care requires proven clinical therapies, not experimental cosmetic workarounds.
I couldn't agree more. And, as we conclude this analysis, there's a broader consideration that extends way beyond the physics of lasers and the regulatory loopholes of the FDA.
What's that?
Well, as we observe the aesthetic industry increasingly merge with the field of gynecology, we have to ask a really difficult sociological question. What happens when our culture's profound obsession with anti-aging moves beyond the visible wrinkles on our faces and begins medicalizing the natural physiological aging process of our internal organs?
Wow, that is a great point. Are we truly treating a complex medical dysfunction, or are we just treating a societal expectation that a woman's body should never be allowed to age, even internally? It is a question regarding how much risk we are willing to accept in pursuit of an aesthetic ideal, and it is absolutely something for you to ponder long after you hit pause. Thanks for joining us on this deep dive.